I'm David Adams. It's my great pleasure to welcome you to the 5th ATS Mitral Conclave.
I'm Dr. Randy Martin, joined by a dear friend and a colleague that I've learned a lot from, Ani from Mount Sinai. Thank you so much for joining me.
Thank you, Randy.
You've been an integral part not only of the mitral valve and the heart failure program at Mount Sinai, but this program especially. You gave a talk this morning that I thought was kind of interestingly titled, which is the dysfunctional ventricle. Tell me a little bit about that.
Well, essentially, there are patients who meet indication for surgery for either primary or secondary mitral regurgitation who also have severe left ventricular dysfunction. So we're talking of people with an ejection fraction, say in the 15 to 30% range. And the question is what we do with those patients.
And what do we do with those patients?
Well, I think the emphasis from our talk was that the first step has to be to evaluate the patient. We want to be sure that there's a reasonable chance that they will benefit from surgery.
Right.
And benefit usually means that the ventricle has some capacity to recover once the mitral valve is fixed and the other abnormalities such as coronary artery disease are dealt with.
Right.
And that usually rests on the presence of viability, which we know from imaging.
Ani, is there a size? You know, we were talking recently about the disproportionate proportion in MR paper, and Paul Graberns talks about that. But is there a size of the ventricle and its function that precludes operating on the mitral valve, and you're thinking more of LVADs and transplants?
Yeah, when we have an end diastolic dimension that starts to approach 7 centimeters, we get very concerned. And with that, we look at the thickness of the walls. If we have a thinned out ventricle, or there's evidence of scar on either the echocardiography or magnetic resonance imaging, then those are the ones that we feel we should be thinking of transplantation or ventricular assist device therapy.
What about the mid-range? So let's say somebody says we've got a 6/8 ventricle and we've got an EF of 40% and have severe MR.
So in a case like
what
that,
do you do with those? But they're very symptomatic.
So if they're very symptomatic, do they have coronary artery disease, or
Yeah,
they might?
Let's say they might.
So let's say they have coronary artery disease. We want to see whether there's any potential for revascularization. So if there's anything that has not been revascularized, we would want to see whether they could be amenable to either coronary stenting or bypass surgery. And then if they are, then we would want to see if there's viability of the myocardium sufficient that we would expect some myocardial recovery.
Right.
And then if there is, then the next step is to see whether we can do the surgery safely. Because some patients might be too high risk to undergo such surgery.
Right.
So we do our usual screening, like using the STS score,
Right.
and then we look for things like frailty and cachexia that might not be captured by the STS score. And then we also want to know more about the right ventricle. Because if the right ventricle is very sick, then the chances of success are also reduced. So those are the main things that we look for.
So you're looking at a composite of things. You're not looking at just MR severity or LV function. You're really looking at a totality of things. I mean, the right ventricle is really critical, I think, in a lot of these people for outcomes. I mean, you might be able to get them through, but then long-term outcomes are hampered if you've got severe RV dysfunction or severe TR, isn't that right?
Yeah, that's correct. And the other thing that we emphasized in our talk today was the importance of a heart failure cardiologist, because really these patients have advanced cardiomyopathy,
Right.
and as you inferred, just fixing the valve dysfunction alone is not what's going to solve the problem. So we want to look at alternatives before we commit patients to surgery. Some patients need a trial of guideline-directed medical therapy first to see what that does, and sometimes the mitral regurgitation can improve. We want to make sure they're not candidates for cardiac resynchronization therapy. We want to make sure there are no other options, like a mitral clip, for example, is increasingly used for some patients with secondary mitral regurgitation. Or some patients might be better served going straight to heart transplantation, as we discussed. And for the elderly patients, sometimes it's kinder not to do an operation, and sometimes just palliating their symptoms might be the better thing to do. So we individualize the care in each patient. And the other thing we talked about is that there's several clinical trials going on of new devices like transcatheter mitral valve replacement and repair, which patients like this may be suited for. So we should look at that too.
Is the pool for people who would benefit from an LVAD increasing, or is it the same? By that I mean, as you learn more and more, you're beginning to get a better feel that this patient who you thought previously might not benefit as much from an LVAD now could, or is it?
Well, the pool is increasing mainly because the devices are getting better, and the surgical procedures and perioperative care is also getting better. So we're able to do these procedures with less upfront risk. And once you can reduce upfront risk, then the chances of the benefit outweighing the risk go up. So we are doing more and more of these procedures on patients who we wouldn't be doing them 5 years ago.
But transplant, if you had an unlimited supply of donor hearts, would be a very viable option in some of these patients. Isn't that correct?
Yes, it would, but as you know, we would never get.
No, we're not getting there. What's your take on the COAP trial? Not COAP versus mitral FR, but the COAP trial.
I think to me the most important thing I learned from the COAP trial was that medical therapy works, and that for a lot of patients, medical therapy alone could improve their symptoms and reduce the mitral regurgitation. But on the flip side, the other thing I learned is that whatever we do, the prognosis seems to be quite poor for this patient group, because although the survival was better in the patients who received the clip device, the 3-year survival was still quite sobering. And I think it shows that we haven't yet got anywhere close to the solution for these patients who have functional mitral regurgitation and depressed ventricular function.
All good point. I mean, this and all the points, the dysfunctional ventricle, I like that name. Thank you very much for, as always, I learned from you. Enjoy being with you.
Thank you very much, Randy. Thank you.
Thank you, and thank you very much for joining us.